Okay, hello everyone. My name is Nader Dahdaleh. I'll be giving this sessions talk today, and I think the oral boards are coming up maybe in the next 2 to 3 weeks. The American Association of Neurological Surgeons oral board exam part 2. So I thought to dedicate this session to the oral boards, just give it's not by any means a comprehensive review. However, I think there are a few pearls and a few tips that I hope that whoever's sitting for it may find useful. Um, and let me advance the slides here. So, I mean, in general, this is a serious exam, right? So the attitude should be one that invites seriousness and preparation. So, leading to the oral boards, I think every day the surgeon should read about 30 to 60 minutes, and then to dedicate about a couple of weeks where you're off duty, meaning no call, no elective cases, just to kind of be in the atmosphere of daily preparation and in the zone. So, and this exam is actually a fair exam, in my opinion. It's about knowledge and strategy. So there's a strategy towards it because it's for the neurosurgeons sitting for it. It's 3 sessions, and each session is about 45 minutes to 50 minutes. You need to go through 5 cases, and then so the examiner will pace you. They would not let you kind of talk freely, and then you're losing time and you're not making progress because you need to finish at least 5 cases in that 45 or 50 minutes. And the American Boards of Neurological Surgery exam is 3 components. One is a general session, so it's mainly a session dedicated to how you handle cases on call, whatever comes in, how do you manage patients mainly on call as a general neurosurgeon. The second session, you can do another general session, will be more involved in terms of, cases that you see in clinic, or you can choose a subspecialty session, either spine, vascular, or functional pediatrics. And, the cases then that are more, it's the things that you do as a subspecialized neurosurgeon in clinic mainly and on call. It's no tricks. It's a fair exam. They will examine about common pathologies, and it's mainly also they want to test that you're a safe surgeon, right? Now, the third session is they ask about your own cases. You submit your cases, and they will pick about 10, and then they'll go over maybe 5. So I find that last session is the one that you have the most control over because you know your cases. You should know them inside out, and they usually pick cases that you've had a complication with, or the cases that you don't do frequently. Let's say you do spine day in, day out, and then you're doing like a peripheral nerve, a couple of peripheral nerve. Most likely they'll pick up that peripheral nerve case because that's not something that necessarily you do or she does every day. Moving on, trauma. Anytime you see a trauma case like this subdural hematoma, this is a spine-focused session, but I must go over a couple of tips that pertain to cranial neurosurgery, especially for the general session. So anytime you see a trauma case like this, knee-jerk reaction, you need to go over the ABCs. As soon as you mention them, then they keep moving. You're not gonna really elaborate too much of it, but they need to, the examiner wanna ensure that you understand that, airway, breathing, circulation come before disability, which is the neurological exam. So this is an acute subdural hematoma. I'd say, okay, polytrauma case. So, okay, I'll check the ABCs and involve the trauma team. And then you move forward and you describe what you see. Similarly, on the right side, that's a fracture dislocation. Same thing. ABCs, then you move on and you zoom into how do you want to manage this case. So that's one tip. The other one is these are ring enhancing lesions, supratentorial, but each pathology is different. So keep your differential broad. When you see the ring enhancing lesion, you can say, okay, that's a ring enhancing lesion, can be infection, inflammation, or tumor. Okay. And then based on further imaging or further sequences, you can narrow down the diagnosis, and then that would lead you to a treatment or treatment options. So this is on the left side. That's a ring enhancing lesion. It's a GBM. This one, there's restriction on diffusion. So you gotta think about an abscess. And this is an incomplete ring enhancing, that's periventricular lesion. Incomplete ring enhancement equals tumefactive MS. And that's a case that you don't want to neither biopsy nor resect, because that's inflammation. And you always make the diagnosis with an LP, low volume LP. So that's the case that you don't want to biopsy. Okay, but they're not going to give you zebras. They're going to give you clearly, if they want to show you tumefactive MS, it's going to be clearly an incomplete ring enhancing lesion. It's not going to be a complete, and it's just a zebra. So keep your differential broad. Again, never biopsy inflammation. This is a patient with neurosarcoid, comes in with progressive myelopathy, and the diagnosis should be made with an LP. Okay, and then with CT chest abdomen, you see mediastinal lymph nodes, and then an LP would show with a high ACE level. That's diagnostic. You don't want to biopsy this lesion either, and you can see it's definitely doesn't expand the cord. It enhances, and it's just definitely suspicious for an inflammatory process. Now, this is a surgical exam. You're not going to see many non-surgical cases. You will see probably 1 out of 10. Because remember, this is a surgical exam. Most of the pathology you're going to be encountering would need surgical attention. Okay, however, keep in mind there are non-surgical entities that one should be well versed with. You may be asked about one of them. This is a neurosarcoid, vitamin B12 deficiency, ALS, NPH, and sorry, not NPH, a neurosarcoid. This, I put NPH here because that's part of the differential diagnosis of gait ataxia. So see, this is treated with steroids and methotrexate, and it resolves. Patient did well. Again, pay attention, be critical of assessing the radiological imaging. So this is an MR. You don't want to just zoom in and say, okay, degenerative disc disease, spondylosis L4551, and be missing on cord signal change here on the conus and the dural AV fistula. So, you kind of be comprehensive, pay attention to details, and take about 30 seconds, a minute, looking at the image before start speaking. Now, you got to be asked at the end of each case how to manage a complication. Every single case will be associated with a complication. And the complications are not infinite, they're finite. So probably there are 7 or 8 potential complications that you need to go through the steps on how to manage these complications. It's like an algorithm, and you need to go through it fast. You don't want to think about it too much. So you need to know how to manage a status epilepticus, dural sinus injury, air embolism, ICP management. CSF leak is a big one in the spine session. So, you get a CSF leak, bring the patient back, open up, get the microscope in, find where the leak is, either primarily close it or patch it. Then TIS-seal or TACO-seal, and then CSF tight closure of the fascia. And you put a lumbar drain, and you drain for 7 days. You don't want to be incomplete managing complication. Supremely aggressive managing complications up front. So you don't want to go back and forth. You don't put a lumbar drain. They say, okay, it leaked again. They bring them back, and you got to put a lumbar drain. Just be aggressive up front. And then definitely change in neural monitoring signals. Same thing. Go through the algorithm, check the leads, communicate with anesthesia, increase the blood pressure, perhaps give some steroids, check the labs, and reverse the last step. And if those do not improve, you either do a wake-up test or you abort the case. You can't finish a case without the diagnosis as what's caused the changes in neural monitoring signal. Other thing is also vertebral artery injury, too. That's also a common complication that you may be asked how to manage the vert injuries, because they're common while exposing or placing screws, particularly C1 and C2. I put together, this is put together this primer, just a brief primer that I thought it may be helpful published in 2021 in one of the AANS spine section newsletter. It's the stuff that I just mentioned, just being methodological in how to approach a case, and send it to everybody, or whoever's interested, I can send them a copy. So going back, general session. So what are the spine pathologies that are encountered in the general session and in the spine session? The general session, you need to know, again, how to manage patients who come in through the ED mainly when you're on call. Central cord syndrome, that's a big one. Okay, admit the patient, ICU, head of bed less than 30, and then I usually operate on them the same admission. If they'll plateau after 2 to 3 days, they'll improve a little bit, and then you can pull the trigger. There's evidence operating on these patients within 24 hours is safe, but usually, as long as you walk through your logic behind why you want to operate on them, like after 2 to 3 days, want to, ensure that, they're hemodynamically stable. Perhaps some of them are sick, they're aspirin pravics, so want to reverse these. And then I usually operate on the same admission, either anterior or posterior decompression infusion, and then they can be discharged to rehab. Cauda equina, big one, due to disc herniation or tumor, emergency surgery. Spinal fractures, you need to understand the classification systems, SLIC and TLICs. Managing discitis osteomyelitis. If they give you a discitis osteomyelitis case, most likely it's surgical, although most of them in real life they aren't, but they'll give you either one with a deformity or with a deficit that you take to the operating room. And then you'll see one, again, non-surgical case, most likely in the general session, either MS, ALS, or vitamin B12 deficiency. Now in the spine session, again, spinal infections are common, spinal fractures, tumors, extradural, intradural. Intradural do not need instrumentation. Extradural, sure. Sometimes you need to instrument them. Most of the time, yes, like metastasis or like a huge dumbbell-shaped schwannoma, intra and extradural. These may need instrumentation. Degenerative disc disease, CSM, cervical spondylitic myelopathy, common. If you see a patient with multi-level disease, elderly, don't be scared of doing a C2 to T2 or an O to T2 if the patient has a retroodontoid pannus, or a C1 to T2. Like, do what you think is correct and reasonable, even if it's a long, big construct. Lumbar stenosis, with or without spondylolisthesis. If it's, you can do a decompression only if patient has a listhesis, as long as not too much back pain and there's no instability. That's reasonable. Spontaneous CSF leaks, from a spinal source, like a venous fistula or just a dural ectasia at the level of this, nerve root, axilla. So you do a dynamic myelogram, you find where the leak is, and then you walk through your algorithm. Deformity, yes. In the spine session, you will be asked to fix a deformity, but they want to see your understanding of the spinopelvic parameters. Like if there's a mismatch between pelvic incidence lumbar lordosis of 30 degrees, you need to understand the corrective modalities and their power of correction. Like an ALIF, you can get about 15 degrees, perhaps 10, 15 degrees. A TLIF 5 to 6 degrees with bilateral facetectomies. SPO is 5 degrees. PSO you can get 30 degrees. So you need to fix the mismatch with a variety of options of corrective modalities. They're not gonna have you do an en bloc spondylectomy, for instance. That's not something that is, even for a spine specialist, necessarily as a common pathology, but you need to at least make a diagnosis. Primary spinal tumors. So let's keep moving here. So I'll go through some cases. This is a 74-year-old gentleman who presents primarily with dysphagia. Actually, the patient has aspirated multiple times, twice needing Heimlich maneuver to save his life. He also has numbness in both hands, and he had a history of prior ACDF. His exam is only positive for a Hoffman's. So what do we see here? This is a lateral X-ray. And it shows the previous ACDF here, standalone cage, and then you see multi-level spondylosis, but you also see big syndesmophytes or osteophytes that perhaps may be causing some of the significant dysphagia that the patient's having. Next, obviously, you got to get an MRI. You see the stenosis has some myelopathy, but his main complaint is the dysphagia due to the anterior huge osteophytes compressing probably the esophagus. You confirmed that with swallow study with barium swallow. This is thin liquids, he did okay, but he aspirated on thicker liquids. So you confirm the diagnosis, ensure that speech, specialist would document the source of the dysphagia location. And how do you manage this? You got to do an osteophytectomy. And I usually do a fusion too. On this guy, the decision was easy because he has myelopathy too. But I would do a fusion. I would not do necessarily a standalone osteophytectomy. The reason being, I think that it's the motion that invites the buildup of these osteophytes. I had patients I've done a posterior fusion. They didn't have dysphagia, but for myelopathy, and then on subsequent imaging, those osteophytes disappeared. So there's evidence that that motion would be would explain some of the developing of those osteophytes. So this is the post-op X-ray, and he improved significantly. His dysphagia improved significantly, even when he was in the hospital, oddly, because you would expect some dysphagia because just the retraction and the procedure itself, but he did good. So this is a 78-year-old gentleman, almost an octogenarian, presenting with numbness in both upper and lower extremities and gait ataxia. He's myelopathic, and he has 4+ out of 5 with his hand intrinsics. And this is the MR of the cervical spine. Okay, and then what do we see? We see stenosis here at C1, C2, mainly due to a retroodontoid pannus. He doesn't have rheumatoid arthritis. It's just no history of RA. So this pannus is most likely CPPD, calcium pyrophosphate dihydrate. You can see here an increase in the ADI here. So there may be there's subluxation of C1 over C2. So this instability is probably the source of the pannus. So what do we do with this patient? Obviously, he's symptomatic, has myelopathy, severe compression. Retroodontoid pannus equals posterior decompression fusion, C1, C2, or C1 to C3. If there's not too much good fixation in the lateral mass of C1, can go to the occiput. So never going anteriorly is a good idea because these pannuses will shrink with the fusion itself, okay? Rarely you would need to do an endoscopic or a transoral or a transnasal approach to resect the pannus itself. So you do a C1 to C3 fusion, and then he did well. I usually document the resolution of the pannus with an MR. I've seen them resorb as early as 6 weeks. So you can see here resorption of the pannus. I'll still do a decompression so that you can, get symptom relief, sooner. You don't want to like just fuse and then wait for the pannus to resorb. I'll decompress as well, too. Although it's not wrong to just fuse, but I would decompress as well. So that's a common pathology and patients, octogenarians mainly, and patients in the late 70s that I find confined to that age group, CPPD panni or pannuses. Okay. Next up is this lady, 64, who noted numbness in her hands for about 2 years. First, over the past 6 months, she also had gait dystaxia. She's myelopathic, wrist reflexes. And she had some mild sensory deficit on exam as well. So they'll present this, you look at it, and they'll move to the imaging. They're not going to tell you, okay, what would you obtain? So they'll move it. There's not too much time, right? Like it's 5 cases minimum over 45 minutes. So got to keep moving. So you can see this lesion ventral to the cord. And you want to put it in a compartment because Putting it in a compartment will dictate further differential diagnosis. So this is intradural, extramedullary. So intradural, extramedullary, benign tumors. Meningioma versus a nerve sheath tumor, neurofibroma or schwannoma. So that's your differential. Definitely there are rare, metastasis, stuff like that, but common things are common. So you put it in a compartment, intradural, extramedullary, benign tumors, extradural, they're usual malignant metastasis, or primary spine tumors, but more commonly are the metastases. And then intramedularly, astrocytoma, ependymoma, and hemangioblastoma. So you look at this, okay, that's the pathology that explains our symptoms. And this is further imaging. That's T2 sagittal axial, sorry, motion artifact here. You can see here an arachnoid cleft. So there's an arachnoid cleft. So that tells us most likely it's a meningioma more than schwannoma or neurofibroma. So it's ventral, but there's a window. So now, how do you want to resect this? Anterior approach, never, right? Never. So intradural tumors, posterior approach, every single time. You don't do a corpectomy, then open up the dura ventrally and do something that's super unusual. You can do that, but that's not the right necessarily right or common practice. And always get those tumors out dorsally with a laminectomy. You can open the dura, and there's always a window where you can resect the tumor. And this is intraoperative image. That's cranial, caudal, medial, lateral. That's the spinal cord here. Stays suture in the dentate ligament. That's a C2 nerve root, and this is a tumor. It's the laminectomy, C2 and C3, I think. We spared C1. You see it, and then you can debulk it. I don't like to remove them en bloc if they're large, because you put tension on the spinal cord. You don't want to really manipulate the spinal cord ever, or very minimally. You can put this stay and rotate it a little bit, and then you find the plane, and then use the CUSA, and then remove it. We spared that nerve root. You can sacrifice it, but we spared it in this case. That's a post-op scan. So you'll see, you're probably going to encounter a tumor, whether it's intradural or extradural, but I think nearly guaranteed you'll probably see a tumor in the spine session. This is a 45-year-old lady, professor of finance, came to the ED with a 3-day history of lower back pain, and then 1-day history of lower extremity weakness and urinary frequency. Her exam is pretty concerning. So she had diminished sensation in her feet, decreased perineal sensation, decreased rectal tone, and 2 out of 5 with dorsiflexion and plantar flexion. So localizing to the cauda equina. So that's an emergency. This is the image. Oh, I should have moved it up, but you can see here is a huge disc herniation here, huge disc herniation, causing severe stenosis, obliteration of the fecal sac here at L5S1. So this is cauda equina due to disc herniation. Now, most common causes of cauda equina aren't a disc herniation; they're usually tumors or a fracture. But this is a disc herniation, and you always want to. I know there's evidence within 24 hours or what have you. Anytime you see an emergency, do it emergently, even if it's in the middle of the night. Always assume that you're working in the best hospital possible with all possible resources available 24/7. You don't want to tell the examiner, no, I don't want to do it with the B team and the C team. It's the A team 24/7 in the oral boards. So this is an emergency. Take the patient to the OR, and you do a decompression. I did this minimally invasively, but if you want to do it open, you can. But you want to ensure you got the job done. So you need to ultrasound, make sure that the pathology is gone, and ensure a good outcome, because sometimes you may need to repeat the image because the patient may have a persistent deficit and want to document that the pathology is gone after the operation. Now, we didn't talk about complications. With this case, probably we'll get a CSF leak. And, bring the patient back, get the microscope, find where the leak is. If it's primarily, if you can primarily approximate it. If that's impossible, then you patch, and then you CSF type closure, lumbar drain. Not only lumbar drain or only surgery, both. Okay, aggressively managing complications is essential. This is another lady, rheumatoid arthritis. She's 60 years old with RA. Okay, so anytime you see this, you want to start thinking about the pathologies that are associated with rheumatoid arthritis. She had a 6 months history of progressively worsening neck pain, severe, and her neurological exam is normal. So this is her scan, flexion, extension. Okay, so you have RA, immediately you pay attention to the craniovertebral junction, right? Like atlantoaxial subluxation, C1, C2 instability. You can see anterior translation, the ADI elevates here and it reduces here. So that's maybe 7 and that's 1. So there's instability. Now that's common in rheumatoid arthritis patient. Doesn't mean you see this, you want to operate on it. No, you know, that's a diagnosis. You can definitely treat it conservatively. Contact her rheumatologist, make sure the RA meds are optimized and manage the pain. Because that's not uncommon in patients with RA, okay? But certainly you want to document there's no spinal cord compression, right? Like there's no compression here. So that's what was done. The rheumatologist was contacted and they optimized things. However, the patient didn't get better. She progressively was having severe neck pain. Like when she moves her neck, a lot of pain, C2, sometimes radiculopathy. And no benefit. So now you can pull the trigger on an operation, okay? And how do you fix it? The C1, C2 fusion. Now, here, the possible complication will be avert injury, but how do you want to manage that? Okay, you, it depends on where you are with the case, but you should not continue. You should, let's say if you did one side, you can put the rod, and then you started the other side, you get the avert injury, you need to tamponade it, blow seal, and then you abort, and you get your colleagues from vascular surgery, neurosurgery, endovascular to embolize the avert and control the bleed. But you shouldn't continue with the case. What are the other pathologies you encounter with RA? 3 pathologies: C1, C2 subluxation, very common, retroodontoid rheumatoid pannus, and subaxial stepwise spondylolisthesis. So these are the 3 pathologies you encounter in patients with RA. Retroodontoid pannus, it's treated similarly. The rheumatoid pannus is treated similarly like CPP pannus, so posterior decompression fusion. O to C2, O to C3, C1, C2. You choose based on fixation points and based on bone health. Now, C1, C2 should be sufficient. However, sometimes we go to the occiput for many different reasons. Some of it is like there's not too much good fixation point in C1, like one lateral mass is nearly gone, so you need to go up. But it should be sufficient to do atlantoaxial arthrodesis for retroodontoid pannus. Don't have to do more. Another one is thoracolumbar fractures, the spine-specific session. This is a burst fracture with posterior ligamentous disruption, so that's an unstable injury. You will be asked, okay, are you aware of any classification system that will help you manage or make the decision whether or not to operate on this patient? Say yes, the TLX. What is the TLX? It looks at 3 things: injury, morphology, neurological exam, and the integrity of the PL, posterior ligamentous complex. And then you see compression fracture, get 1 point, a distraction injury, 4 points, and a burst, 2 points. And then neurological status, intact, 0, cauda equina or conus, complete injury, 2, incomplete, 3. So you need to know these numbers, and then they add up. If it's less than 4, you can brace. If it's more than 4, you should operate. What surgery? Depends. You can do a front back, you can do just posterior 1 segment, all depends on the load sharing score. But there's no right answer if you want to operate. So as long as you identify the unstable injury and you operate on it, then I think you'll be in good shape. Now, if it's a 4, you can go either way. And if you want to err on being more aggressive, err on stabilizing an unstable spine or a possibly unstable spine. So this is a patient, that's a quick one. 28, jumped from a story building, attempting suicide, schizophrenia, bipolar disorder. On exam, 0 out of 5. So that's a trauma case. You gotta say ABCs immediately. And then 0 out of 5, plantar dorsiflexion on one side, the other side 2 out of 5. Pretty bad exam. Saddle paresthesia, and then decreased sensitive power L4 through S2. And this is the injury. You don't have to really calculate the TLIX to make a decision because that's certainly operative, but let's calculate the TLIX. That's a burst fracture with an incomplete injury. So 3 plus 2, that's a 5. So that's operative. And that's canal is totally obliterated. So this is the fusion here. You know, load sharing. Let's talk about load sharing. If when to do a corpectomy, when not to do. So 2 options. If the load sharing score, which looks at the anterior middle column comminution, like it's comminution, kyphosis, and splaying of the fragments. If it's more than 6, then that's a high load sharing demand. So you need to either do a front back short segment, meaning corpectomy, mirror it in the back with screws, or posterior only long segment. Both answers are correct. So if the load sharing score more than 6, front back short segment versus posterior long segment. Now, if you're not sure, posterior long segment every single time. No problem. Another one is thoracic disc herniation. Okay, this one, right? Myelopathy, thoracic disc herniation, T7, T8. First thing you need to know is whether it's calcified or not. If it's not calcified, then you can go posterior, meaning transpedicular. Okay, if it's calcified, you gotta go transthoracic. Okay, usually if it's soft and on the towards one side, the transpedicular approach. So you take the pedicle below the pathology, and then you remove the frag and push it into the trough. Now, if it's calcified or central, you got to go transthoracic. Okay, so you don't have to memorize all the in-between approaches between a transthoracic and a dorsal transpedicular approach, which is the extracavitary and all that stuff. Just the 2 extremes. Remember, one of 2 approaches: soft disc, central, or a calcified disc, transthoracic, dorsal, transpedicular, if it's a soft disc, off to the side most commonly. So this, how do you want to localize? You want to put a fiducial, okay? Because that's many things can happen and that can go wrong in this case. One of it is wrong level surgery. How do you avoid that? You do a fiducial, you got to do a post-CT, post-fiducial CT to confirm that where the pathology is. And then you find it right away in surgery. And you do the surgery. Laminectomy, transpedicular. That's the disc. That's the spinal cord. You remove it, but how do you ensure that the job is done? You do an ultrasound. That's before. See, that's the spinal cord. That's the, because usually you gotta make sure that you get the job done. And how do you see it through the spinal cord? You use ultrasound. And then that's a disc herniated spinal cord. And this is after. Okay. What is the complication here? Loss of signals. Okay, loss of signals. So that's, you go through the algorithm. Once you start talking about the algorithm, you move to the next case, right? Like then they know that you have prepared. You don't want to think about it too much. This should be, going through the algorithm should be a brainstem process. It should not even reach the frontal lobes in terms of thinking about it. Like you think about, like think about your resident calling middle of the night with status epilepticus. You don't think about it. Just tell them this Ativan, right? Like, and then phosphoenatomic loading goes, and then prolapse, and then pentabark then you want to get a scan to see what the cause of the status epilepticus. So you need, these are algorithms. You need to go memorize them and regurgitate them right away when you're asked about them. You don't want to think about it. It should be a knee-jerk response. This is I'm gonna end here soon. Again, this is a patient with neurosarcoid. Actually, this is a real case that I was asked by neurology to biopsy. Said no, doesn't look like a tumor. And even if it does, no harm in doing an LP. Okay, so this is definitely all right. Look at this edema here, hollow cord edema, and then have this fluffy, non-specific enhancement. That's rarely, it doesn't expand the cord. Insidious presentation. So LP, you see it's inflammatory, protein is high, and then the ACE levels are high. So that's neurosarcoid. Then we image hilar lymph nodes. Then you can biopsy these. This is biopsyable. Non-caseating granuloma. Methotrexate prednisone result. You biopsy this, you know, you run the risk of not passing the exam or not doing well, something like that. But no one's gonna biopsy this. Okay, I think I'm gonna let me go through the one more case here. Hey, it's a pediatrics, like 13, but it was a bigger person. So he's 13, but he's really big. Who presented with back pain for a week after he fell while playing football with his friends. Axial back pain, neurologically normal. And this is the CT scan. You can see here bilateral pars fractures. Okay, it's not a defect, that's a fracture, stress fracture because of the fall. So how do you want to manage this? Bracing, right? Like that's like when patient was braced. You can see the pars fracture here. 4 months, not getting any better. He's a bigger guy, BMI elevated, 40 BMI. So probably that's what, you know, it stressed the spine, and it's, you know, the loads are more than what the spine would tolerate physiologically, perhaps. That's why he didn't heal with a brace. So 4 months later, severe pain on narcotics, skipping school classes. Comes back, his mom is really concerned. Repeat scan 4 months later, worse. It's not good. So, so what do you want to do next? Now, I want to ensure that's the source of the pain, which is, and then want to ensure that there's no subluxation, because if there's subluxation, then you need to fuse segmentally. If there's no subluxation, then you can do a pars repair. We confirmed this with a pars injection, numbed it, pain went away. So we're certain that it's not muscular, it's actually the fracture that's causing the pain. And that's the pars repair. And this is the, so sublaminar hook, pedicle screw, you can see the fracture healed. And then his pain is 0. So that's all I have. I'm going to open it up for questions. I'm going to have some more cases, but you guys got the gist of it. And, you know, I hope whoever's sitting for the boards will do well. And, you know, it's, you know, apprehensions, you know, people are, you know, worried about it, but, you know, enjoy the process, the studying process. The day itself, it's not super bad, you know, friendly, and be comfortable. No, you know, look at the images, everything you'll see, you've seen before, and it's a fair exam, no zebras, and they'll pace you. Got to get through 5 cases. I mean, I got through 5 cases barely. One session I started with a 6, but the time was up. But other than that, it was paced, and you know, it was a good day. It was a good day. All right, guys. So, do you have any questions? Let me see if and the who was managing the. Let's see. No, where's the chat box?
Yes, Dr. Dahdaleh.
Yeah, I see here chat. In case of vertebral artery, in cases of vert artery injury, Money would not advise to use flow seal. Yep, correct. Yes, I misspoke. I agree with that. You tamponade, you do gel foam and pressure, and you can perhaps put a shorter screw, and then but you gotta abort because of, you know, you need to, this bleeding needs to stop before you close, and then but you don't continue. on the other side. Let's say you have a injury on one side, you know, most of the time you get away with it. But if you go to the other side, get another injury, that's game over. So I would abort anytime you see it. But I agree. Yeah, it can travel proximally. I agree with that. Yeah. Okay, guys, you know who's presenting next week? We'll figure this out. We'll be in touch.
We will post it on Twitter.
Was that again?
We will post it on
We'll
Twitter.
post it. Okay. All right. Thanks, everybody. I hope this session was helpful, and you know, it'll be posted. Thank you so much, Razia, and we'll post it on our YouTube channel. And good luck to whoever is sitting for the oral boards. Speak soon.